New ADC data _progress and highlight challenges in HER2+ breast cancer and TNBC management. In a recent peer exchange, breast cancer experts discussed updates from ESMO 2025, including practice-informing data with recent data readouts with treatment standards like trastuzumab deruxtecan, T-DXd, in HER2, and sacituzumab govitecan, Trodelvy, may refine the optimal use of these agents in the HER2-positive and triple-negative breast cancer treatment settings. Additionally, continued research with newer antibody-drug conjugates, ADCs, may further expand the number of available treatment options for select patients. Now that we have data for T-DXd in the neoadjuvant and the adjuvant settings, we're all going to have to grapple with those in clinic, Neil M. Iyengar, MD, said in a recent OncLive peer exchange. This is a testament to how the clinical paradigm changes so quickly and how we have to frame our interpretation of clinical trials. The adjuvant therapy paradigm is shifting under our feet. Once we get those long-term data, interpreting those is going to be interesting in the context of what we're doing now in clinic. During the panel discussion, breast cancer experts gathered to discuss updates in HER2-positive and triple-negative disease management that were presented at the 2025 European Society for Medical Oncology, ESMO, Congress, https://www.onclive.com/conference/ESMO-Congress. They highlighted key datasets that support the use of T-DXd across several HER2-positive treatment settings, the efficacy of the HER2-targeted ADC trastuzumab botidotin, A166, and data with TROP2-directed ADCs that may broaden treatment options for patients with triple-negative breast cancer, TNBC. Considerations about balancing the efficacy and safety profiles of ADCs, as well as the need to determine treatment de-escalation strategies for select patients, featured in the discussion as well. How might new T-DXd data help pinpoint the role of this agent across the neoadjuvant and adjuvant HER2-positive breast cancer settings? Data from the Phase 3 DESTINY-Breast11 trial, https://www.onclive.com/view/neoadjuvant-TDXd+-THP-yields-PCR-benefit-in-high-risk-HER2-early-breast-cancer, NCT05113251, presented at ESMO 2025, reinforced the benefit of using T-DXd-based regimens in the neoadjuvant HER2-positive setting. This trial, which investigated neoadjuvant T-DXd plus a taxane, trastuzumab, Herceptin, and pertuzumab, Perjeta, THP, N=321, in patients with high-risk, HER2-positive early breast cancer, showed improved outcomes, including a pathologic complete response, PCR, rate of 67.3% versus 56.3% in those treated with neoadjuvant dose-dense doxorubicin and cyclophosphamide, DDAC-THP, N=320, difference, 11.2%, 95% CI, 4.0%-18.3% wink with tongue sticking out equals 0.003.1. This advantage was observed regardless of hormone receptor status. Event-free survival, EFS, trends also favored the T-DXd arm, which had a 24-month EFS rate of 96.9%, 95% CI, 93.5% to 98.6%, versus 93.1%, 95% CI, 88.7% to 95.8%, in the DDAC-THP arm. Despite the efficacy of T-DXd in this population, the panelists acknowledged the toxicity profile associated with this ADC. In DESTINY-Breast11, any grade adverse effects, AEs, were reported in 98.1% of patients who received T-DXd, and the rate of grade 3 or higher AEs in this arm was 37.5%. Any grade adjudicated interstitial lung disease, ILD, and left ventricular dysfunction were observed in 4.4% and 1.3% of patients, respectively. Although these rates were lower than those in the DDAC-THP arm, the experts emphasized the importance of AE monitoring and investigating treatment de-escalation strategies for eligible patients. Hopefully someday we'll be able to figure out who those patients are who could use less therapy and still achieve a PCR, Sarah A. Hurwitz, MD, FACP, said. We're grappling with what happens if you use T-DXd/THP in the neoadjuvant setting and there's residual disease at the time of surgery. Do you give more T-DXd? That wasn't tested. Do you give trastuzumab emtansine, T-DM1, Kadcyla? In this study, only 52.6% of the patients received T-DM1 for residual disease. That's probably speaking to the fact that this was an international study, and the study did not provide T-DM1 in the adjuvant setting. Interim findings from the Phase 3 DESTINY-Breast05 trial, https://www.onclive.com/view/T-DXd-improves-IDFS-and-DFS- versus T-DM1-HER2-breast-cancer- with-residual-invasive-disease, NCT 04622319, also presented at ESMO 2025, may help refine the role of T-DXd in the adjuvant HER2-positive paradigm. This trial evaluated T-DXd versus T-DM1 in patients with high-risk, HER2-positive primary breast cancer with residual invasive disease after neoadjuvant therapy. In the trial, patients who received T-DXd, N equals 818, achieved a 3-year invasive disease-free survival rate of 92.4%, 95% CI, 89.7% to 94.4%, compared with 83.7%, 95% CI, 80.2% to 86.7%, among those who received T-DM1. N equals 817.2. The T-DXd benefit translated to a 53% reduction in the risk of invasive disease or death versus T-DM1, N equals 817, HR, 0.47. 95% CI, 0.34-0.66 wink with tongue sticking out, 0.0001. In patients who are estrogen receptor positive, we're going to be drawing in other therapies besides HER2-directed therapy. William J. Gradishar, MD, noted about the overall changes that may occur in the HER2-positive treatment paradigm. The adjuvant component of our therapies are going to change just as the front end is changing. We may be using CDK4/6 inhibitors, endocrine therapy, and an HP regimen or a T-DXd regimen postoperatively. Those are still open questions with the new data in the preoperative setting. How might the further investigation of standard and novel ADCs continue to move the needle in HER2-positive breast cancer management? Data from the primary analysis of the Phase 3 DESTINY-Breast09 trial, https://www.onclive.com/view/first-line-T-DXd+-PFS-benefit-in-HER2-advanced-breast-cancer, NCT 04784715, which were presented at the 2025 American Society for Clinical Oncology, ASCO, annual meeting, https://www.onclive.com/conference/ASCO, showed that among patients with HER2-positive unresectable or metastatic breast cancer, the median progression-free survival, PFS, by BACR was 40.7 months, 95% CI. 36.5 not calculable, NC, with T-DXd plus pertuzumab, N equals 383, versus 26.9 months, 95% CI, 21.8 NC, with THP, N equals 387, HR, 0.56, 95% CI, 0.44-0.71 wink with tongue sticking out, 0.00001. Point 3. These data supported the July 2025 FDA Breakthrough Therapy designation, https://www.ncliv.com/VIW/FDA grants Breakthrough Therapy designation to frontline T-DXd plus pertuzumab in HER2-metastatic breast cancer. That was granted to T-DXd plus pertuzumab for this indication. Point 4. Findings from the subgroup analysis of DESTINY-Breast09, https://www.ncliv.com/VIW/DESTINY-Breast subgroup data shows clinically meaningful PFS benefit T-DXd pertuzumab in HER2 breast cancer. Presented at ESMO 2025 demonstrated the superior efficacy